Okay guys, we'll make a start. My name's Chris Miles. I'm one of the physiotherapists here at Apostherapy. My background is a sports science degree, which I specialised in biomechanics and sport injury, and I've worked in both the NHS and private practice. I now obviously work as a senior apostherapist based at the London Clinic. Okay. So how this webinar will work today, you'll obviously all be able to hear myself, but I will be unable to hear you. So if you have any questions as we go throughout the webinar, you can type them into the bottom right hand screen, and we'll try and answer them as we go along. And any questions that are left unanswered, we'll be replying to them as we go and at the end of the webinar individually. Can everyone hear me okay? If you can just type into the box on the bottom right hand screen, just let us know that you can hear me. Okay, so the agenda for today, we're going to be talking about an introduction into neuromuscular control and biomechanics aspects of knee osteoarthritis, and then we'll be introducing the next Apostherapy's dual mode of action in terms of a novel treatment approach to treating knee arthritis. So first of all, looking at knee arthritis in terms of the biomechanics and neuromuscular control. So when we think about knee arthritis, we used to think of it as just a bone or a joint problem. But as time's gone on, we've now recognized that it's not only just a bone and joint problem, but also there's a neuromuscular element to it. When we look at x-rays, we know that there's a poor correlation between the symptoms actually felt in the joint and actually the biomechanical element and the actual joint destruction itself. So if you think about the Kalgan-Lawrence classification of knee arthritis, we know that this doesn't necessarily match perfectly with the patient's symptoms. So this is evident that it's not just a bone or a joint problem. Other aspects that lead us to believe this is the changes in the neuromuscular system. Even before changes actually appear in terms of symptoms, we know that the weaker quadriceps is a common feature of people with knee arthritis before any symptoms actually appear. The hamstrings actually increase in their activity compared to the control groups in patients with knee arthritic changes. And medial bracing, so the muscles around the medial aspect of the knee and increased co-contraction of the muscles, is something that we often see with patients with knee arthritis, and we'll be talking a little bit later on in the presentation about why this might actually be the case. So there's two key considerations when looking at knee arthritis: the neuromuscular arm, so all the muscles and the soft tissue, and the biomechanical arm. So looking at the biomechanics of how the joint is actually functioning. So today we'll be looking at how these actually are linked together and how the combined impact of both of them can actually progress to the disease. So the neuromuscular arm we'll start with first. We're looking at the problem. We're looking at adverse muscle activity, so something that's not normal. Now that can be something like the quadriceps being weaker, as we said, or the hamstrings working a bit too hard, or just something that's abnormal. Now what this does is it reduces the function of the knee joint and the joint stability. And this inevitably leads on to pain. Now what happens with pain is that we know that it leads back to changing of the muscular activity, and so straight away, before we've even considered the joint itself, we have a vicious cycle. So the first question put towards your listeners today is, how do we often see in our objective assessment that supports evidence of neuromuscular compensations? So changes in the muscles, how do we see it during our assessments? I'll just give you a couple of minutes just to write down and share your views, and then we'll feedback. Okay, just give you a couple more minutes to type. Okay, so we've got a few people pointing out that maybe muscle atrophy, so quad muscles weakening. A couple of people put how hamstrings can become very tight. Okay, changes in gait patterns. Yep, so we can see that by people having problems with their muscles, they change the way they're walking. So going back to, okay. So just reflect on a couple of things that people have shared there. We know that the muscle atrophy can be something. So we might notice that the size in the muscle, and particularly in the quadricep muscles, may change. Also, some people mentioned that the hamstring muscles become overactive. So what we actually see often during palpation of the patients with knee arthritis is that the pes and serine area becomes very tender. This is due to the muscles working a bit too hard throughout your gait cycle and through daily activities, and actually causing pain away from the actual joint area itself. But we'll come back to the reason why this might be the case a bit of it further on. So the biomechanical arm. If you think about the problem, it's the changes in the mechanics. And we know when treating various patients, sporting conditions, knee arthritis, how biomechanics has a role to play and can put excessive or abnormal loads on the joints or even soft tissues. And what this does, it leads to increased pain, so increased compression of the joint, and therefore affects the way we can carry out our day-to-day activities. So question 2, how do we normally see the changes in biomechanics with knee arthritis? If you'd like to just include how we might see this in your assessment. Okay, so someone's putting change in the frontal plane. So absolutely, in terms of the biomechanics, changes from a varus or valgus deformity that we see. What's the most common one that we see in knee arthritis? I'll just give you a minute to give your answers. Okay, so someone's mentioned knee valgus, and well, with the correlation of hip, which is actually a very common correlation that we see. In terms of knee osteoarthritis, actually the varus alignment is the most common pattern that we see. So when we're walking, if we think about the load passing through the joint, it's normally due through the medial side of the joint, and which is why about 70% of the load is put on through the medial joint. So naturally, as the joint degenerates, it increases the varus alignment. And someone also mentioned about fixed flexion, so changes in the sagittal plane because of these bracing hamstrings. Over time, our patients with knee arthritis lose their ability to fully extend the knee. Okay. So when we're looking at these patients, looking at a healthy individual and a patient with knee arthritis, we said that there's a ground reaction force that acts upon the joint, okay, that passes inside the knee joint and actually creates what we call a knee adductor moment, which is acted on the joint, and this is completely normal. Now, if we think about the varus alignment and how that bone actually increases, what it does is increase the knee adductor moment. So therefore, it's going to lead to increased adduction moment and increased load on the medial compartment of the knee, and therefore often more pain. And this is really well recognized in terms of research and very well accepted. So making the link between the two. If we think about the most common form of knee arthritis in the medial joint line, we think it's because of the ground reaction force is going through the inside of the knee. This actually increases that knee adductor moment and therefore increases the compression on the medial joint of the knee. Because of this change in biomechanics, it actually has effect on the soft tissue also. So if we think about the ligaments that are actually around the knee, on the lateral side of the knee and the medial side, they change in terms of how they are processed and that proprioceptive input into the knee joint. So on the outside of the knee, we get what we call true laxity. So the ligaments are stretched and it's giving feedback to the joint of where it is in space. But on the medial side, we actually lose that proprioceptive input. So it's called pseudo-laxity, a phenomenon known as pseudo-laxity. Lots of research done on it. And because of this change in the proprioceptive input, on the lateral side, we have the normal proprioception. On the medial side, we have a reduced proprioceptive input, and that's going to have an effect on the output in terms of how muscle control. So because the brain perceives this decreased proprioception, it perceives it gets less information from the joint, and therefore tells the muscles to respond and actually provide that joint stability. So if we reflect back in terms of the knee and the pes and serine pain, we can understand why the muscles around the inside of the knee are trying to give a little bit more input into the joint. And the problem is with this increased activity, because the muscles cross over the joint, they actually further compress the joint and increase the knee adductor moment. And again, we have that vicious cycle of pain. So we know that there's the mechanical arm of the knee arthritis and the neuromuscular arm. And when these actually present in a clinic, people mentioned earlier about the gait changes or gait deviations. Our body's very clever at trying to compensate for these. So it leads us on to pathological gait patterns. Okay, so we'll have a look at an example of this, which is one of our patients from the clinic. So if I just play you this video. This is a lady that's got bilateral knee arthritis, I think medial compartment and patellofemoral. You can see how she's struggling with her walking. She's obviously in a lot of pain and quite a severe antalgic gait. So she's adopted different strategies to try and maybe avoid the pain. Her muscles are bracing. She's not flexing particularly that right knee as she's going through the stance phase and into the swing. And her muscles and her brain have learnt these motor patterns, and this is something that again increases that vicious cycle. So if we reflect on current treatments that we have, what do we use currently in terms of treating knee arthritis? If you guys want to share and just write down in the comments box, and we'll reflect back in a second. Okay, so lots of people mentioned quad strengthening exercises. We, classically give these static quad exercises or straight leg raises to try and build up the quads muscles. We know that there's that link between the quad weakness and knee arthritis. A couple of other people put wobble boards, so training the body maybe in a weight bearing situation, which is good and very functional. Also very good for muscle control. Just give you another minute. And so people have also mentioned about how the pelvis control and how treating muscles further up the kinetic chain is also important. Absolutely. Okay, so now we'll move on. So to review these treatments that we have. So from a neuromuscular perspective, the treatment objective is to reduce the pain, to introduce a perturbation to challenge this proprioceptive system. So if we again think about that lack of proprioceptive input that we're getting, we need to try and address that. And because of these pathological patterns, we want it to be subconscious. We want a high number of repetitions of a desired movement pattern to try and re-educate the body. So as we said, we use wobble boards, use exercises, lots of different variations that people use. They have their limitations. So the ones that unfortunately sometimes it doesn't improve the patient's symptoms. Maybe some things like not being functional. We know how patients sometimes don't comply as much as we want to. They can actually be painful, which is going to lead in and feed into this low compliance. If it's a painful exercise to do, they're not going to want to do it. Okay, and then obviously you can only get in a limited amount of repetitions throughout the day. Now, in terms of the biomechanical arm, the treatment objective is to manipulate the moment. So we spoke about the knee adductor moment. If we try and change that, we can actually reduce the loads passing through the joint and therefore reduce the pain. The current treatments that we have, things like wedging, lateral wedges, orthotics, braces, examples here. So we have lateral wedges, which is a very common one way of reducing the knee adductor moment, and an offloader brace. So again, just taking the pressure off of that joint can actually reduce the symptoms, which is really effective. Again, have some limitations in terms of that they're quite passive. As soon as you take them away, the joint's in the same situation. The muscles are responding and working in the same way. And that carryover, because we're not addressing the muscular or the neuromuscular component, we're not going to get that ongoing and long-term response. So again, if we reflect back, the two main considerations is that there's two arms, the biomechanical arm and neuromuscular arm of knee arthritis, and each arm is interdependent. So they work in correlation, they both feed into each other. So it's really important that we address both arms at the same time. Sometimes the current treatments, which don't actually make long-term changes, is maybe because they're not addressing one or other component. Okay, so we need to address both. Any questions at this point before we move on? I'll just give you a couple of minutes just to ask anything that springs to mind, and then we'll move on. I'll just give you a couple more minutes. Okay, so one of our listeners has asked if there are any new treatments for pain relief. Well, we're going to come on to that now. So we'll talk about how at Apostherapy we treat knee arthritis and how we can address these. Okay. So introducing Apostherapy, it has a dual mode of action. So we're trying to address the both arms of knee arthritis. So there's the biomechanical arm, so to improve the functional alignment and therefore manipulate the moments and reduce the pain. Okay, we know that the muscles work better if there's less pain. And then the neuromuscular arm, we want to introduce some perturbation. We want a high number of repetitions, and so this is something that we aim to do with the device. So there's three components of Apostherapy. It's a personalized pathway of care. The actual device itself is a breakthrough in terms of mechanics and treating the knee joint, and it's a very easy treatment to do. So we're going to go into each aspect of the treatment and talk about how we use it. So we're all specially trained physiotherapists here at Apostherapy. We do a normal physio assessment like you would in any other patient. And we spend a long time with our patients looking from a gait analysis perspective as well. So we use a computerized gait analysis looking at spatial temporal figures, which actually help us assess the patient in terms of suitability and obviously monitor the patient throughout their course of the treatment to review their progress. So it's a really invaluable tool, and it's something that we really put a lot of emphasis on with our patients, that we can actually monitor this from a subjective but also an objective measure. The biomechanical device itself is a shoe which has rails on the bottom, and the actual, I have a picture of it here. The actual shoe itself has the two pods. Okay, so it's the pods that actually are delivering the treatment, if you like. Because they sit on the back and the front, we can manipulate the movements and the moments of the joint throughout the gait cycle. So throughout the stance phase, we can move these moments in order to reduce the pressure and the load on the structures that we want. Okay. And there's an endless amount of versatility with the treatment. We can change lots of different things, including the convexity of the pods to increase the perturbation. We can change the position of the pods. We can change the resilience, so a soft or a hard counter with the floor. So we can change lots of different things to make it very specific to each patient. So if we look at the biomechanical arm, we spoke earlier about how we want to manipulate the knee adductor moment. On this picture here, it shows where the ground reaction force actually goes with the black arrow, and the knee adductor moment, which is the line going into the middle of the joint. So with the Apostherapy device, what direction do you think that we would move this to actually help with the medial knee pain or medial knee arthritis? Can you fill in your answers, and then we'll feed back. So some people were saying medially, and some people were saying laterally. Well, please say the people that said laterally are correct. By changing the position of the pod to the lateral side, we're reducing that knee adductor moment. So you can see that the knee adductor moment becomes less, therefore reducing the compressive forces on the medial compartment, and therefore reducing pain. Okay, so that's one way that we can actually reduce pain levels in these patients. Now, from a neuromuscular perspective, because of the convexity of the pods on the bottom, every time they make a step, it actually introduces a controlled level of instability that stimulates that proprioceptive input into the joint. Okay, so it asks the body to respond a little bit differently, and it asks the muscles to improve the stability in the joint, and therefore, again, reduce pain. And that through that number of repetitions, that's where we get the carryover from. So this is a video of the same patient that we said earlier. This is at the initial consultation. So on the left, we have the patient before calibration. Okay, so again, severe antalgic gait, a lot of listing to one side, reduced knee flexion, and lots of pain. And on the right-hand side, once we've manipulated the moments around the joint through the positioning of the pods, we can see that straight away she's walking quicker. Her pain is a lot less, and her speed and her normal walking pattern, so she's now bending that right knee a lot better, a lot smoother, and so most importantly, she's reporting less pain. One of our listeners is asking, will it stop the degenerative changes in the joint? We can't stop the degenerative changes in the joint, but we can slow down the vicious cycle. So we spoke about earlier how the mechanical arm and the neuromuscular arm interact and actually can almost speed up that compression in the medial compartment. By addressing these, we can actually take the pressure away and almost stop that vicious cycle. Okay, so we're not stopping the degenerative process, but we want to slow it down and stop the vicious cycle of pain. Okay, and one of our listeners is asked to just go back and explain the lateral displacement of the pod. So I'm just going to go back a couple of slides. Okay, so we spoke earlier about the knee adductor moment and how it passes through the inside of the knee joint. So with a varus alignment, that knee adductor moment gets larger. Okay, a varus knee alignment, which is most common presentation we see in medial knee arthritis. If we move the pod laterally, it actually changes where the ground reaction force travels through the joint and therefore reduces the knee adductor moment and therefore the compressive forces on the medial knee. Okay, so by changing the position of the pod, we can actually reduce the loads and just redistribute them. Okay. Okay. And one of the listeners is asking if it's moved too laterally, is there a risk of increasing inverting the foot? Obviously, it's a big it's a balancing act. We don't want to have a knock-on effect to other foot postures and things, but we're talking very minute changes in the actual movement of the pod. They're very very small changes, but can actually make a huge difference in the joint and the kinematic chain further up. Okay, so we'll just go back to where we were before. So we saw that video. So the third component of Apostherapy is that it's very easy to use. It's a functional rehabilitation system. Patients use it very short periods of the day just to work around their normal day-to-day activities. So because of this, it's very easy to use, so the compliance rates goes up. The number of repetitions that they can get throughout that time is very good. And again, because of the combination of the biomechanical element, we're actually reducing the pain. So patients often like wearing them, and therefore they get a huge amount of repetition in them, and therefore leads on to long-term benefits. So the synergistic approach, because we're addressing the functional alignment and the perturbation at the same time, the end goal is to return these patients to normal patterns of movement. So if we look at the patient again, this is about 5 months into the treatment, so at the lady's third follow-up session. Again, on the left-hand side, initial consultation, and on the right-hand side, follow-up 3. We can see that benefits that we got actually in the system. Now she's not wearing any of the devices, but she's maintained them normal movement patterns. So her pain is not there anymore. It's much reduced, and then bad habits and then compensations that she had initially, her muscles have re-educated and actually control the knee joint a lot better. Okay, so we'll move on. Any questions at this point? Any questions about Apostherapy or how it works or anything else? One of our listeners is asked if there's a gap between the two pods, does it change from a 3-rocker system to a 2-rocker system? The answer being you still have the 3 rockers, but because there's only 2 pods, it just changes how you address them. So you can move and manipulate the two pods to actually influence the three rocker system. One of our patients has asked, can we avoid higher tibial osteotomy surgery by wearing this? Again, depending on the patient, depending on their suitability, when patients come for their assessment, it always depends on their severity and how far down the line they are in terms of the osteoarthritic disease. But in theory, patients going for high tibial osteotomies are the generally younger, more active patients. So we often have a very good result with these patients. And one of our patients has asked, do we increase the convexity throughout the treatment? And the answer is absolutely yes. So as the neuromuscular system can control the knee and neighboring joints better, we gradually increase the challenge, so continue to get benefits as the treatment progresses. And one of the listeners asks, have you seen any corresponding changes in the strength of various surrounding muscles? The answer being, we certainly address everything from the lower back downwards. So by addressing the kinematic chain, we are going to be having influences on the surrounding muscles. In terms of strength, we're looking at muscle control rather than pure strength. So again, it's more about stability rather than pure strength gains. Okay, any other questions? Just give you another minute or two. Okay, and one of the listeners has asked if we can treat back pain with this technology, and the answer is yes. Again, through manipulating the moments acting on the back and supporting the various muscles that are involved, we can actually have a really good effect on the lower back pain as well. Often we see our patients that have a combination of symptoms, so sometimes they have knee pain and back pain, and we can treat both in conjunction with each other. Just give you another minute or two. Okay, so we have lots of different research through our research department and published in multitude of different journals. And if you're interested in these, we can send these out to you via email. And I'll see if you have any other questions about today. You can contact us through various different avenues. You can visit our website, www.apostherapy.co.uk. You can email myself if you have any questions about what we've discussed today in the webinar, chris.miles@apostherapy.co.uk. If anyone's interested in coming to visit the clinic to see what we do and come watch a consultation, or if you just wish to discuss any patients that you think might be suitable and you want to know a little bit more, please get in contact. And if anyone's interested in becoming a qualified apostherapist to deliver the apostherapy in your clinics, again, get in touch and we can have a chat to you about that. And just the last question today, one of the listeners has asked, is there any other pathologies that we use to treat? We use this to treat, again, anything from the lower back downwards. So there's multitudes of pathologies that we can actually address. Same methodology applies. We change by changing the loads and by changing the muscles and how they actually respond. We can have a huge effect on lots of lower limb and lower back conditions. So, for example, Achilles tendinopathies, tibialis posterior tendinopathies, patellofemoral pain syndrome, OA of the hip, lower back pain, just to name a few. And someone's asked if there's any contraindications to using the pods. In terms of contraindications, it comes down to safety. So when our patients come in for the initial assessment, they have to pass certain balance tests because we're challenging the balance systems. So if they're unsafe at all, then they're not allowed to start the treatment. And obviously suitability. If we're not likely to help the patients, if they're too severe and they're suitable for other treatments, then we will refer on to the various different specialities. Someone's asked us, what about do we treat children? The answer is yes. In certain situations, if they're suitable for the treatment, various neurological conditions or again orthopedic conditions is something that we do treat. Okay, so someone's asking if the pods are custom made. The actual shoe itself obviously comes in the various sizes, but the pods come in various different shapes and sizes, which we calibrate according to the patient and their symptoms. So we can change these as the treatment progresses, but you don't actually change the shoe itself. Someone's asked if the pods can correct the varus or valgus alignment in children. The answer to that being alignment is something that we do treat, but as we know, the alignment changes throughout childhood and growth anyway. So it's something that if a patient isn't having symptoms and isn't having any problems with, we wouldn't want to get involved and treat the condition. But it's something that is causing the patient a problem, then it's certainly something that we would have a look at. And the changes in terms of knee arthritis, obviously see a lot of patients that have varus, but also patients that have valgus alignment. The methodology changes slightly, so it really depends on the patients in terms of what we're trying to achieve. Okay, one last question. Someone's asked if will the patient's symptoms recur if they're not wearing the pods for a while. We know that knee arthritis is a degenerative condition. It's likely to continue to change and progress as we get older. We have many of our patients actually come and see us, maybe not quite so regularly, but afterwards, after they've finished the course of treatment, to recalibrate and just to check that they're maintaining their benefits as they go through the treatment. So yes, patients decide on an individual basis whether they want to continue using them to maintain, or they wait until their symptoms might change and then come back and recalibrate. Okay, Would anyone like to find out more information about Apostherapy? If you could just, there's a poll, so if you could just answer yes or no, and we can follow up this by email afterwards if you're interested. Brilliant, thank you. Okay, so with that's concluded our webinar for today. Thank you everyone for joining us, and I hope it's been informative, and we look forward to hearing from you if you have any further questions. Have a nice day.